Good morning and welcome to the GenQA Focus On webinar for November. I'm Rebecca Treacy, Deputy Director for the Genomics Quality Assessment Scheme, or GenQA. I'm delighted to welcome you today to this webinar on our molecular newborn screening EQAs, with particular emphasis on severe combined immunodeficiencies, or SCID. Today, I'm joined by Dr. Stuart Adams, Joint Organisational Lead Healthcare Scientist at Great Ormond Street Hospital for Children in London, and Marta Blom, Clinical Researcher in Paediatrics at the Leiden University Medical Centre in the Netherlands. Today, we will be covering a brief introduction to the GenQA Molecular Newborn Screening EQAs, the SCID clinical details, the challenges of testing TRECs in the UK, testing of SCID in the Netherlands and Europe, and then details of the SCID EQA for 2020 and 2021. And finally, we will have a live Q&A session at the end. Please could I ask that everybody who is listening to this remains on mute for the duration of the webinar and raise any questions that they wish to do so via the chat facility, and we will then address these during the live Q&A session. So firstly, an introduction to the GenQA Molecular Newborn Screening EQAs. So as I'm sure you're aware, all babies in England have a heel prick test at 5 days of life, and they are routinely tested for 9 rare genetic disorders. Testing is performed using biochemical assays. However, for some of these disorders, a second-level molecular test may be indicated, such as a raised immunoreactive trypsinogen level for cystic fibrosis or raised acyl carnitines for MCAD. So for the EQAs that we offer, the first one was cystic fibrosis, which was offered initially in 2007. There were various challenges around offering this, as the UK newborn screening strategy was to test for 4 common variants only. And for non-UK laboratories, they had a different testing strategy. However, we have now been running this for over 10 years. The second newborn screening EQA that we offer was for MCAD, and this consisted of testing for the common variant only. For both of these EQAs, we provide up to 4 distributions per year with a total of 8 blood spots provided. These are genotyping only EQAs, so performance is based on reporting the correct genotype and using standard HGVS nomenclature. And these are supported by the UK Newborn Screening Committee and Public Health England. The blood samples for these EQAs are sourced from clinicians' laboratories and directly from patients. The blood is spotted onto neonatal screening cards, and the samples are sent to 2 laboratories for independent validation. Participant laboratories receive these samples for EQA testing using their standard testing protocols, and the results can be submitted as a laboratory report or by completing a pro forma. The results are scored according to professional guidelines. We also collect details of the methodology used so that laboratories can see across the board what testing is offered by via laboratories participating in this EQA. One thing that has changed very recently in 2020 is that we are now providing referral cards with these samples, which include patient details. So in 2019, the UK National Screening Committee recommended an NHS evaluation in 2020 for screening babies for SCID. The evaluation results will inform a recommendation about whether screening for SCID should become part of the NHS newborn Bloodspot screening programme in England. There are 6 laboratories in England participating in this evaluation, and part of it is to provide an EQA. So I will now pass over to Dr. Stuart Adams, who is one of these laboratories taking part in the evaluation and who will tell us a bit more about SCID.
Good morning. As Becky just said, I work at Great Ormond Street Hospital. I'm not working in the newborn screening labs, but I was part of the working group to set this up, and have been working on SCID for many years now. And next slide, please. So a bit of background to SCID itself. SCID stands for Severe Combined Immunodeficiency, and it's an inborn error that leads to a failing immune system. There are numerous underlying genetic lesions that cause SCID, and some of yet are unknown. But they do all have one common feature, and that is an absence of naive T cells and something called TRECs. Next slide, please. So obviously, if these babies are born without a functioning immune system, then they are susceptible to numerous infections, viral infections, bacterial infections, and fungal infections. And while they have some protection against infection from maternal antibodies, they tend to succumb to infection within typically the first 6 months of life, and it's universally fatal within a year of life. Typically, the babies will present with a respiratory infection, and they'll end up going to the GP and their local hospital, and then things get elevated bit by bit until they finally get referred to a specialist centre where they get a definitive diagnosis of SCID. And by this time, these children are really sick. Now, although this is a universally fatal condition, we have got a definitive cure. And one of these cures is a bone marrow transplant. But there are a number of factors which affect the successful outcome of a bone marrow transplant. Next slide, please. So a study that was published some time ago now showed what are the most important factors in influencing a successful BMT. And one of them, or the key driver actually for success, is the age at which the baby is transplanted. So in the top box up here, you can see that the age of transplantation is a key factor. So if a baby is transplanted at the age of 6 months or less, they have a much better outcome than if they're transplanted at the age of 6 to 11 months or older. And this, if you look at the bottom box, this is entirely due to the fact that as the baby gets older, they are more likely to have infection on board, particularly pulmonary infection. So the key is to transplant these babies as early as possible before they get these onboard infections. Next slide, please. So we carried out a study at Great Ormond Street and Newcastle in the UK, which are the two centres for transplanting SCID babies. And the study focused on looking at the outcome for probands versus the outcome for second or third children within a family. And in the proband cohort, this is a historical cohort. The first proband cohort, you could see that 35% of these children died before they even got to transplant, and this was due to infection. Of those that did get to transplant, a further 39% died during the procedure, and this is purely because of the babies being so poorly going into transplant. So when you look at the overall survival, it's really quite poor at around 40%. When you look in the second or third sibling outcomes, where the babies are of course diagnosed at birth, there were only one death before transplant, and that was with a family who refused to accept their child had SCID and refused treatment. Of those that progressed to transplant, the outcome was much more successful. And actually, as this is a historical cohort, those that did die during transplant were predominantly due to the availabilities of donors that we wouldn't necessarily use now. So the survival in this historical cohort was 90%, and we think this would probably be about 100% now. We would be surprised if we lost a SCID baby if we picked them up at birth. So there was our rationale for needing to treat SCID as early as possible. So then how do we do this? So next slide, please. Well, we need a marker for SCID. And as I've said, there are numerous different genetic lesions. So we can't just use genetic mutation for this because there are too many. But what we can use is a marker for T cell production. And this works, if we look back at the pluripotent stem cells in the bone marrow, this is where all of our immune cells are made. And they form either the myeloid stem cells, which go on to make our granulocytes, phagocytes, erythrocytes, and so on. And also make out our lymphoid stem cells, which form either B cells, which make antibodies, and obviously we've read about those in the news lately, or T cells. Now, T cells undergo a specific rearrangement process in the thymus, and the thymus is a little organ that sits in front of the heart. And it's really important. These T cells come out of the bone marrow, they make their way to the thymus, and they're processed before they enter the bloodstream. And what happens in the thymus during this processing stage is that the T cell receptor genes are rearranged so that each T cell that comes out of the thymus has a unique T cell receptor. And when you think about it, you need a big pool of T cells in circulation to fight off a broad range of viruses that you're going to encounter during life. And so this T cell gene rearrangement is absolutely essential in generating a big repertoire of functional T cells to give you immunity. Next slide, please. So this is the most sciencey slide I've got. And essentially it just gives a précis of this T cell gene rearrangement. So in the thymus, there are various different parts to the T cell receptor genes, and these are chopped up and then put back together in a random fashion. And when they do this, they generate a functional T cell receptor that's unique for that T cell. But during this process, a bit of DNA is cut out and it's excised and it's left over. And that piece of DNA then circularizes, and we called it a T cell receptor excision circle. And that's just known as the TREC. So if we measure a TREC, we're essentially measuring one T cell being produced in the thymus. And this is the defect in SCID babies. None of them actually have TRECs because none of them are producing viable T cells that enter the bloodstream. Next slide, please. So there are two broad technologies that we can use to measure TRECs. One, both of them are based on PCR, but one of them is an endpoint PCR process. And this kit is made by PerkinElmer, and 3 of the 6 newborn screening labs in the pilot will be using this technology. And then there's a real-time quantitative PCR kit made by a company called ImmunoIVD and called Spotted, and that will run in the other 3 labs. And so obviously they're the 2 technologies that we need to compare as part of the EQA schemes. Next slide, please. So that was a summary of SCID, the clinical condition, and TRECs, and how we can measure them. So now we're going to go into the nitty-gritty of the challenges of testing using TRECs in the UK. So TRECs are, as I've said, circular pieces of DNA, and they can be amplified by PCR with small DNA primers that bind to the TRECs. Now, apologies if this is very patronizing, but I know some of the newborn screening labs, PCR is a very new process. Essentially, the TRECs that are formed during T cell recombination events are unique. So there isn't, one TREC is different to the next TREC. So it's been very hard to identify a single assay that will work on these TRECs that are different from one T cell to another. And it was about 25, 30 years ago now that a chap called Daniel Dweck in the States identified a conserved region in the TRECs. So a piece of DNA in that TREC that's actually conserved. And we designed PCR primers that bind to that conserved bit. And we also use DNA primers for a control gene called beta-actin, although it can be any gene that's essential for cell survival. And that's just an internal quality control. So PCR is carried out, and it's just a 3-step heat incubation process. Quite simply, you loot your DNA from the blood spot, typically by heating it with a buffer. Then you subject that DNA to PCR, you heat it up to a very high temperature, which causes the double-stranded DNA to separate. Then you cool the mixture down, and at about 50 to 60 degrees, typically your DNA primers will bind. So your TREC primers will bind to the patient DNA if there is any TREC DNA there. And your internal quality control, your beta-actin primers, will bind to that piece of DNA as well. Then the mixture is heated up again to 72 degrees, and you get copying of the incomplete strand by a DNA polymerase. And that makes a second copy of your TREC and a second copy of your beta-actin. You repeat this process 30 to 40 cycles, and you have many trillions of copies of your target DNA if they were present in the first place. Next slide, please. So the endpoint PCR method relies on a fluorescent probe for the TRECs and a fluorescent probe for the beta-actin being present in the mixture and binding at the end of the reaction. So PCR is carried out, you generate your PCR products, and then the probe binds. And then you put that on a plate reader and it measures the level of fluorescence. So the more you've got of the TRECs, the more fluorescence you get. And the more beta-actin you've got, the more fluorescence you get. And of course, if you've got no TRECs at all, you won't get any TRECs fluorescence. And it's really straightforward. There are limitations to this method, but it's about as simple as you can get, really. Next slide, please. The alternative method is the real-time quantitative PCR method, and this relies on the probes binding to the DNA during amplification itself. And every time that piece of DNA is copied, you get some fluorescence released. And so along the x-axis here on this figure, you've got the number of cycles of PCR from 0 up to 40, and up the y-axis you've got the fluorescence released by the mixture. And the more DNA you put in, or the more of your target DNA that's there, the earlier you can detect fluorescence. So here's just an example with 25 nanograms of DNA. A typical gene is fluorescing after only about 4 or 5 cycles, and with very small amounts of DNA, it's not fluorescing until 30 odd cycles. And so in this way, we can also measure the levels of TRECs and the levels of beta-actin. There are advantages to this method, although it is a little bit more technically demanding and requires a little bit more analysis at the back end, but there are other advantages to doing this method. Next slide, please. Crucially, both methods should be sensitive at low levels. In a SCID baby, we would expect to see 0 TRECs or at the most 3-4 TRECs, and both methods will be able to detect these sorts of low levels or 0 TRECs. But across the whole range of the assay, quantitative PCR is likely to be more accurate. So your quantitative PCR will give you a numerical answer right up in the normal range and in the borderline range and at low levels, whereas the endpoint PCR is very much a yes or no kind of assay. So I think it's fair to ask these questions of both methods. And is one more sensitive than the other? And will they both pick up 0 or level or very low TRECs equally? We would expect this to be the case, but of course, until we test this at a population level, we won't know. And so subsequently, are different cutoffs for SCID babies needed? Next slide, please. So this leads me on to the algorithm that we're of course going to use to determine whether a baby should be referred as being a potential SCID baby or not. So the algorithm is based. This isn't finalised. I should add. This is the final algorithm is likely to be like this, but the actual cutoff values are not completely settled on yet. So the day 5 blood spot is taken. We take a single punch. You carry out either assay, and if your TREC levels are above cutoff, SCID is not suspected, and the baby gets a normal result. If the TRECs are below cutoff, we retest the assay in duplicate with repeat duplicate punches from the same blood spot. And if both results are now above cutoff, we would say not SCID. However, if one of the results of the duplicate testing come back as lower than cutoff, we then go on to look at the internal quality control gene. And of course, if the internal quality control gene shows a failure of amplification, then there must have been something wrong with either the assay or the blood spot, and a repeat blood spot is required. Assuming that the control gene gives a level above cutoff, we would then say this baby has the potential to be a SCID baby. Now, this is about as simple as an algorithm gets, and it may change during the pilot study as we gather more data. And we certainly may find that we have different cutoffs between the two methods. Next slide, please. So we can clearly see there's a requirement to have an EQA scheme for SCID testing. It's a new test. It's going to be carried out in a pilot phase at a population level in 6 labs with 2 different methods, which may have different cutoff levels and sensitivities. So GenQA will be sending samples out 6 times per year with 2 samples per round, and we will try and prepare the samples such that they cover normal, SCID positive, i.e. TREC negative, and also samples around cutoff values. And we are welcome to any suggestions on what you want from the EQA if they're not covered by this process. I'm happy to take questions at the end, of course. Thank you very much.
Thank you, Stuart. We will now move over to Marta, who will tell us a little bit about testing for SCID in the Netherlands and Europe.
Thank you, Becky. Good morning, everybody. Today I would like to give you an update about newborn screening for SCID in the Netherlands and close off with a little bit of an update about the rest of Europe. So next slide, please. So the first announcements about newborn screening for SCID in the Netherlands actually date back to 2015, in which our Dutch Health Council came out with this report. It's called Neonatal Screening, New Recommendations, and they recommended to include 14 new disorders in our newborn screening program, including SCID. However, as Stuart just explained, SCID is accompanied with a new assay in our screening laboratory, namely PCR. Therefore, it was also recommended to start with a pilot study. So in 2018, we did a very small pilot study, very comparable to your much bigger pilot study. We analyzed 1,300 newborn screening cards and compared both the endpoint assay from PerkinElmer and the qPCR assay from ImmunoIVD. We thought they were both suitable, sensitive assays. And of course, not only endpoint and qPCR are different methods, there's also some differences in the procedure. For example, the number of manual steps, throughput time, and also punch size. So in the end, we took everything into account and we decided that we would use the ImmunoIVD assay for our pilot study. Next slide, please. So with regard to our pilot study, it's called the SONET study. It's a prospective implementation pilot in 3 provinces of the Netherlands, as you can see here. In 2 of our screening laboratories, we have 5 in total in the Netherlands. And we started in April 2018, and we will continue until December 2020. And starting the 1st of January next year, we will have national implementation of newborn screening for SCID in the Netherlands, and our pilot study will be done. So next slide, please. So I thought it would be interesting for you to share some of the results that we found so far. So from April 2018 to November 2020, we have now screened over 192 newborns, and this is so far what we found. So first of all, we had 62 referrals. These were the newborns with the low TREC levels that were referred to an academic center for follow-up diagnostics. And on the other hand, I also highlighted here the preterms that we found. So what we found were 61 preterms who also presented with low TREC levels at birth. And as we know that premature birth is also associated with a more underdeveloped immune system, we decided in our screening algorithm to not refer these infants, but to repeat a second heel prick at the corrected age of 37 weeks. And we actually saw that in 59 of the cases, all TREC levels were actually normalized at 37 weeks. So we have prevented a numerous amount of referrals by using this extra step in our screening algorithm. Next slide, please. So this is what we do if we have an infant with low TREC levels. First, the evaluation by a pediatrician, and we state that this has to be done within 72 hours after the abnormal TREC result. And the first step into follow-up diagnostics is actually flow cytometry. So it's a measurement of your total amount of T cells, because of course the T cells are the most important step in your follow-up diagnostics. Once you have measured your T cells, there's actually 3 potential outcomes. On the completely right side, you would see completely normal T cells. We would state, well, this is a false positive case and no follow-up has to be endorsed. On the complete left side, you have your absent naive T cells. Well, this is merely a SCID case, so you would state continue with genetic analysis, but also start, for example, with your bone marrow stem cell transplantation workup. And then we have the middle category, which is a little bit more of a difficult category. You would see low or abnormal T cells, not completely normal, but also not completely absent. In this case, we would advise to do some additional diagnostics, also have a counseling with a geneticist, and then make more of an individual management strategy per patient. Next slide, please. So what were the 62 referrals that we had so far? Well, first of all, the 62 referrals lead us to a referral rate of 0.03%. And this is very similar to other countries that have already implemented newborn screening for SCID. So what did we find? First of all, we found one SCID patient. Maybe that was a little bit disappointing for us because based on the incidence in the Netherlands, we would have expected some more. But this is, of course, the problem with incidence. There's a chance that next year we'll find 6 SCID patients. The patient underwent stem cell transplantation, is actually doing great right now. Then we had 8 false positive cases. These are the referrals that actually had completely normal flow cytometry and normal T cells and no follow-up was needed. We have idiopathic lymphocytopenia cases. So there's no genetic defect, but there were low T cells, but not that low that these children would need a stem cell transplantation. We have 2 interesting cases, namely the cartilage hair hypoplasia and Rodman-Thompson syndrome patients, who are both not real SCID patients, but they had severe T cell lymphocytopenia. So both of them actually did get a bone marrow transplantation. And then we have 2 more categories, our T cell impairment syndromes and secondary T cell impairment. And for that, I would like to go to the next slide, please. So secondary findings for newborn screening for SCID, as I already mentioned, is actually very common because there's a lot of other disorders that can also present with low numbers of T cells and therefore low numbers of TRECs at birth. And I just mentioned the syndromes with the T cell impairments. Well, we found plenty of them. So what we found were, for example, DiGeorge syndrome patients, but also Down syndrome patients, and also Noonan is something that we found. But even more, we found causes of secondary T cell impairments. For example, children with congenital anomalies, heart defects, or gastrointestinal anomalies, loss into third space, patients with hydrops, vascular leakage, these were newborns with sepsis. And also if the mother used immunosuppressants medication during the pregnancy, you would see low TRECs at birth. Next slide, please. So during our pilot study, we did not only look at the analytical test qualities of the TREC assay, we also looked into more ethical and cost effectiveness studies. So we did indeed a cost effectiveness study, but we also looked via questionnaire studies amongst parents into untreatable secondary findings for SCID, for example, ataxia telangiectasia. We also asked parents, what do you think about newborn screening for SCID in the Netherlands in general? We are doing something about newborn screening on XLA, or severe B-cell deficiency, which can be detected by TRECs, kappa-deleting recombination excision circles. And for now, I want to highlight also the interviews that we did with parents after an abnormal SCID screening results, so after a referral. Next slide, please. So we asked parents, how did you experience the whole procedure of the referral? And are there any points that we can actually improve in the future? So we interviewed 17 parents, and 12 out of these 17 parents actually stated that they experienced the whole referral procedure as very negative. So in the Netherlands, our general practitioner is actually the one who usually visits parents at home and tells them about the abnormal SCID screening results. However, parents stated that the general practitioner either provided them with too little information or incorrect information, for example, stating that SCID has no treatment. And they also said that the way of delivering this news was very unpleasant, rushed, or via telephone. And in total, actually all parents stated that they experienced significant anxiety and also emotional insecurity during the referral. Some parents even stating that they found this a traumatic experience. So this in total actually gave us something to think about. So what we are doing now is we're also using tandem telephone calls with pediatricians to help. But we also thought maybe there's need for a more targeted screening for SCID in order to reduce the number of incidental secondary findings and also the false positive cases. Next slide, please. So this is a current project that we are doing. We are now looking into second-tier testing after TREC analysis in order to reduce the number of secondary findings and also false positive cases, and also to increase the sensitivity of newborn screening for SCID in total. So we are actually exploring now 3 different options. On the one hand, we are using PCR with different primers, and we are not using the PerkinElmer assay as I discussed before, but PerkinElmer actually has a new assay as well. It's called the EONIS assay. It's a qPCR assay, and it uses some different primers than we are currently using in our immuno-IVD assay. On the other hand, we are looking into epigenetic immune cell counting It's a technique that uses unique epigenetic markers for different kind of leukocytes. And finally, we are also looking in next generation sequencing, which is comparable to what Norway is doing. So they are using next generation sequencing with a dedicated PIT panel, so primary immunodeficiency panel, as a second-tier test after TREC analysis. Next slide, please. So to close off, I want to give a little bit of an introduction into what the rest of the world and also the rest of Europe is doing. And I actually stole this slide from Bobby Gaspar, who presented it at the ACID 2020 online meeting. So let's start in 2009, I think. This was the first time that the UE Council actually recommended to include more primary immunodeficiencies. But then in 2010, actually the major steps were actually taken, because the USA and the US Department of Health actually recommended to implement SCID in their newborn screening program. In 2012, Taiwan actually started with newborn screening for SCID. And then in 2013, some European countries, Tuscany, Italy, so only a part of Italy followed. Ontario and Canada also started with newborn screening for SCID. In 2014, there were some pilot projects in Europe, starting in Andalusia in Spain, but also in France, they did a large pilot study on newborn screening for SCID. In 2015, the Netherlands are stated here, but we didn't actually start. We just had our Dutch Health Council advice at that time. So then in 2017, there's actually more happening in Europe. Iceland implemented newborn screening for SCID, and also Catalonia, Spain, regionally implemented newborn screening for SCID as well. In 2018, Norway followed, and this was also the point that all states in the United States implemented screening for SCID. In 2019, Germany, Sweden, and Switzerland followed with newborn screening for SCID. And now we are in 2020. Indeed, we actually have announced that we will start next year, and Denmark also started. And I actually see that the UK is not implemented in here, but I know that you are also planning your pilot study that will go ahead next year. So next slide, please. Because this was already my final slide, I would like to thank, of course, the other members that are also working on our pilot study in the SONETS group, also our National Institute for Public Health and the Environment. And if there's any questions, I'm happy to answer them via the chat. Thank you for your attention.
Thank you very much, Marta. So to get back to the EQA that we're offering for 2020, we will be having 2 distributions with 8 samples in total. The first distribution has gone out just very recently, and as previously stated, we will be including different sample types, providing normal results, SCID positive, and intermediate results. And the results are to be submitted on a pro forma, and we will be collecting data on the TREC levels, the cutoff levels, and the technique and equipment used. And you can still enroll for round 2 if you have missed round 1 already this year. So then looking forward for 2021, we will be providing 6 distributions on a bi-monthly basis with 12 samples in total. So if you would like any further information on these EQAs, please email us at info@genqa.org. So I would just like to take this opportunity to say thank you to the patients, clinicians and laboratories who have provided us with blood samples for all the molecular newborn screening EQAs which we provide, and take this opportunity to ask if anybody can help with sourcing these patient samples to allow us to continue providing these EQAs. We have various consent forms and things like that that we can provide to allow patients to provide blood samples for EQA purposes. I would also like to thank the validating laboratories, assessors, and of course our participants. And finally, to thank Dr. Stuart Adams and Marta Blom for their really interesting talks that they have provided with us today. Now we will now move on to the question and answer session. We had a number of questions which were emailed into us before the webinar launched, so we will start with some of those. One of the first ones was, will the SCID newborn screening program pick up other conditions in addition to SCID? So Stuart or Marta, would one of you like to answer these for me?
Yeah, I think March has probably answered some of this in her talk. Actually, we will pick up other conditions, as March pointed out. There will be some patients with other severe diseases that are caused by low T cell levels, and we would consider this to be advantageous to pick these up. Have you got anything to add, Marcia?
Yeah, I think from a clinical perspective, we also think that there's an advantage of picking up some of these cases in a very early phase. However, I also heard the more newborn screening world that actually states, well, that's perfect, but we are screening for SCID, and we only want to find SCID patients in order to have 100% sensitivity. But indeed, you would definitely find other cases that are associated with low T cells at birth.
Okay, thank you. The next question is, will the UK screening pilot adjust their screening algorithm or cutoff value for preterm infants?
So this is a tricky question, and it's one that we've been talking about for a while. So certainly most countries that are carrying out newborn screening for SCID do have a adjusted algorithm for preterm infants. At the moment, we have no plans to do so, but obviously, should data be collected during the pilot phase that would require us to test preterms differently, then that option would be explored. What do you do in the Netherlands, Marta?
So what we have done now is that we have an adjustment in our screening algorithm. So if we have low TREC levels below cutoff, we would look at the gestational age, and every newborn before, I think, 37 weeks will receive a second sample collection at the corrected age of 37 weeks. So then you would say, well, the gestational age is now correctly normalized, and then you would also see that TREC levels usually normalize within those weeks.
Yeah, it's useful to know that, actually, isn't it?
I think we have prevented a lot of referrals this way by just asking for a second card when they are a bit older. And as preterms, of course, they are at the NICU, they are very in this protective environment. So if you would have the very, very rare case that you have a preterm with SCID, they would still be in a very protective area with a lot of care and a lot of monitoring as well.
Okay, I think we have another question which is related to this. The cutoff for discriminating potential SCID babies may change during the pilot program. How will we deal with this from an EQA perspective?
Yeah, we're going to have to be fairly reactive to this, aren't we? As we collect data at a population level, it will probably become fairly apparent what our cutoff values ought to be. Now, as part of the pilot study, we have got a pre-implementation phase planned where all 6 laboratories will start running samples and collecting information in advance. So hopefully we will have a defined, fairly rigid cutoff for both methods designed before go live of the pilot. And the EQA scheme will, of course, have to take this on board as they provide samples to participant laboratories.
Okay, I've got one final question here. Punching from the center or the edge of a blood spot has some influence on TREC levels. Do we provide any recommendations for punching in the EQA program?
I don't think we do. Do you, Marcia?
Yeah, well, I was thinking about this question because we see quite some differences from punching from the center of a spot or punching from the side. So what we do here in the lab, we have also other quality assurance programs, for example, the CDC. We then recommend our technicians to very much punch from the center in order to have the most cells there and therefore have the best accurate result.
We are going to be doing some work with Stuart Moat in Wales, who's going to start testing the quality, the effect of spot quality on TREC screening. So we'll probably have some more detail around this over the well, early in the new year actually is when we're going to do this bit of work.
Yeah, that's very interesting because there's also some other factors we have seen as well that influence quality of the blood spots. For example, when spots are dropped from heparin tubes, you won't get any TRECs or beta-actin or anything like that. So that would be a nice study.
Okay, thank you. I don't believe we've had any other questions come through. So I think, and bearing in mind the time as well, I think we should probably move forward to closing this webinar. I would just like to let everyone know that we would appreciate any feedback and that a survey will be sent to registered participants following this webinar. So please do complete the survey and send it back to us. The webinar will be available for participants who have registered for approximately the following month, and then it will go onto our GenQA YouTube channel. So please do subscribe to that, because that's where we have put all of our focus on webinars and other webinars that GenQA have participated in. There will also be participation certificates available for anyone who requires evidence for CPD purposes. And finally, I would just like to say that the focus on topic for December will be the individual online assessment for BRCA variant classification. Oh, we've just had one late question come in, which says, does it make any difference if it's EDTA or fresh blood that's used to generate quality assessment blood spots?
So I can only speak now really from a quality assurance program, but as for screening, we also get sometimes newborn screening cards with EDTA blood. And for TREC analysis, we have seen that it's not really of any influence. Heparin is, but EDTA is not.
Yeah, I was going to echo that actually. For other reasons, we've been running EDTA blood spots in our lab for some time, and we found no effect on any downstream PCR being carried out.
Thank you. So if there are no further questions, then I think I would like to say thank you to both of our speakers, and we look forward to people joining us for one of the next Focus On webinars. So thank you very much and goodbye.